Thank you, Peter, and thank you, Samir, for this incredible privilege. And I was very happy to hear your question, what you just asked about how we rule out invasive fungal disease, because that's exactly what I'm going to talk about with CT imaging. And I have to point out that I have an very important conflict of interest, not just who I work with or do research, but I'm not a radiologist. So why invite somebody like me, a pharmacologist, to come talk about CT scans? I originally started my career at MD Anderson Cancer Center for a long time on the hematology units, both research and clinical, and married an Italian hematologist, and that's how I ended up in Italy. And when I arrived in Bologna, I was surprised to find that they had very low rates of empirical antifungal therapy, and they had a radiology-driven stewardship program. And all we'd been hearing about is biomarkers and how we're going to apply this. And it was the radiologist, who's not even invited to these meetings anymore, who are telling us that, no, you can safely stop antifungal therapy in a high-risk hematology patient. And so I told these guys, you have to start publishing and get the word out, because this is another pathway that we can use in addition to our biomarkers. But I'll start by asking a question, and it involves the idea of contrast. Do you need to give intravenous contrast when you're trying to make a diagnosis of invasive mold disease? When is the role? So if you have a high-risk patient, say a patient with a hematological malignancy, you send them to CT. Do you always avoid contrast? You don't want to take the risk of acute renal injury. Only when a nodule is initially visualized near a large vessel, there could be risk of hemorrhage. Do you consider it routinely in patients who are at low risk for renal injury and who have suspicious lesions? Or maybe only during follow-up if the patient seems to have progressive disease. So let's vote on this. Okay, wow, I'm amazed. Unfortunately, if you were taking the board exam, half of you would have probably failed. The answer, according to recent guidelines, is only when the nodule or mass in CT is near the large vessel. And so there's two very strong statements in, for example, the recent IDSA guidelines, that routine use of contrast during chest CT is not recommended. Strong recommendation, moderate quality of evidence, only give contrast when it's near a vessel. And I agree with you that there may be a role for using contrast more frequently, but this is currently what's in the recommendations. And what the hematologist will say, well, this is written by infectious disease physicians, they're scared to death of nephrotoxicity. You know, we manage it all the time. So maybe the hematologists are not quite as scared of the nephrotoxicity potential of giving iodinated contrast. But I think, as we've heard, especially from Johan's previous talk, this is the problem clinically, that you have a patient who has the risk factors for invasive mold disease. They come in with a CT scan like this, and in general, what we know is that these are highly suggestive, but in many cases nonspecific, and about 50% of the time, the patient does not have invasive mold disease in the lung. They have a bacterial infection, maybe lymphoma or some other process. And when we saddle, especially a patient with a hematological disease, with a diagnosis or a presumptive diagnosis of a fungus, this is a huge problem. It lowers the probability of progressing on chemotherapy on time, of going to transplant. It lowers their probability of achieving complete remission. And in many cases, it means they're going to stay on antifungals for months. And that's going to be an increasing problem with drug interactions with the new therapies. So we really need to have something that improves the specificity, the differentiation between bacterial versus fungal disease. And part of the reason that CT struggles is because of the changes that occur, both in terms of the host immune suppression, as we've heard, but also in the tempo of the major findings. Early in the process of bronchial invasion in the alveolar phase, the findings on CT are often very nonspecific and transient. Now, in a neutropenic patient, they will progress more rapidly to an angioinvasive phase, but as we've heard in the non-neutropenic patients, they may have less characteristic findings, and it's very difficult to say that this is a fungus or something else. And the problem also is the fungal burden is often lower. Serum galactomannan may be undetectable. If they go to a BAL, they may detect by culture a BAL pathogen, but the disease is very indeterminate at this period. When we then go into the angioinvasive phase, it's not quite advancing here. It's struggling. Okay. This is where we begin, as we know, to see the signs that are a little bit more suggestive of the halo signs. But within a week, up to 1/3, even 50% of patients will not have evidence of a halo sign, and will have dense consolidations associated with higher fungal burden, and this is a very nonspecific finding. If patients continue to progress and they have extensive necrosis, you may begin to visualize the hypodense sign, which is fairly uncommon to see without contrast, but it is a fairly suggestive sign of invasive mold disease in persistently neutropenic patients, and often precedes the air crescent sign or cavitation, which is a very late sign. So the problem is that we're often imaging patients at a period where there's these rapid transitions in the appearance of their CT from suggestive but not specific signs to unsuggestive or not necessarily suggestive signs. So the whole idea then is, do we have tools at our disposal? There's lots of things being discussed right now with MRI, PET, new immuno, antigen targets that can be used to improve the specificity, but do we have the tools in hand right now to improve the specificity of CT imaging? And actually, especially in neutropenic patients, when we look at the pathophysiology, with angioinvasion being the key factor and vessel thrombosis being an element, we do have an exam on hand, and that's pulmonary angiography. CT pulmonary angiography is the gold standard test for detecting pulmonary embolus. And so could there be a role for applying CT pulmonary angiography to improve the specificity when we examine these lesions and look for vessel interruption or direct evidence of vessel thrombosis? This was initially suggested by a Swiss group, Sonne and colleagues, that looked at 10 patients, but they did a very detailed investigation, including histology of these lesions, and they performed CT pulmonary angiography. And what they found is that they saw a vessel occlusion sign in 4 out of 5 patients who had documented invasive fungal disease by histology. There was one false negative case, interestingly, a case of mucormycosis. But I think importantly, no vessel occlusion sign was observed in 9 of 9 patients who had an alternatively established diagnosis by culture and histopathology. So it did seem to have improved the specificity of CT. And based on this, before I came to Bologna, they actually instituted a protocol where they thought, yeah, why not do CT pulmonary angiography? And so the protocol was developed that a patient who is going to be referred for chest CT had to have an approval to receive contrast. So not all patients are going, we're trying to screen out patients who will be at risk for acute renal injury. And it became a radiologist-driven process. When the patient was having their basal scan, the radiologist made a determination whether the nodule is suspicious for invasive fungal disease and whether it's accessible for performing CT pulmonary angiography. And this was typically occurring within the first 72 to 120 hours after fever. There was also a couple of other important criteria. If the nodules are too small, less than 10 millimeters, it's difficult to perform the exam or read it, or if the nodules are small and they're at the apex or the base of the lung. And of course, if it was a cavitating infiltrate, you can't look into air and see if there's an occluded vessel. So this is an exclusion criteria. If the patient met this criteria, they went ahead and performed CT pulmonary angiography using contrast media, about half the amount of contrast that's used for a typical abdominal CT in a neutropenic patient. Probably the only thing that's different or unique from other pulmonary angiography is the reconstruction techniques. It does take a little bit of training, but I think that the potential is exciting if you think about this as a test that all hospitals have. And if you can train radiologists to do this, then potentially you can have an answer within 15 minutes about whether this process is angioinvasive and there's thrombosis inside the infiltrates. So within about 15 to 20 minutes, we can say this vessel shows occlusions or not. And our initial experience in Bologna was really agreed with what was shown by Sonne and colleagues, that when we compared patients, these are 2 patients with acute myeloid leukemia. One died with proven invasive aspergillosis, the other had bacterial pneumonia. You can see the difference inside these infiltrates. They're indistinguishable on a typical CT scan, but in the patient who had the documented invasive aspergillosis, you do not see a patent vessel. It's interrupted here, whereas inside the infiltrate of the patient with bacterial pneumonia, we see patent vessels extending through the infiltrate. This is an example of an anesthesiologist who was in consolidation chemotherapy. He was neutropenic. He came to the hospital in severe respiratory difficulty. Initial view of his coronal CT showed these very suspicious infiltrates that certainly could be Pseudomonas, certainly could be other things, but really were concerning for invasive mold. He was started on an antifungal, but when the CT was performed, the radiologist did decide to perform angiography, and you can see inside each of these infiltrates, you can see the patent vessels extending through the infiltrate. And the patient did go to bronchoscopy, and it was demonstrated he had multi-drug resistant Pseudomonas aeruginosa. We treated him colistin and high-dose ceftazidime. He survived. He's back at work. But the good news was, instead of receiving weeks and weeks of antifungal therapy, after the culture, after angiography, he did have a negative galactomannan in serum. We could stop antifungal therapy after 3 days. This is an example of a patient who avoided antifungal therapy altogether, extensively treated lymphoma, presenting with persistent fever on broad-spectrum antimicrobials. When the basal CT was performed, the radiologist decided that angiography was indicated, and you can see patent vessels extending through the infiltrate. And so this was reported immediately to the hematologist. They withheld antifungals. The patient went to a biopsy. This was relapsing lymphoma. Never received antifungal therapy. So there's a lot of advantages of this test, and when we went back and looked at the first 100 patients that were managed with this test and the performance, it seemed that CTPA was, the vessel occlusion sign, was by far the most specific CT sign for patients who had proven or probable invasive mold disease. Now, when you look at specificity, it's a little bit of a difficulty due to the limitations of the guidelines of how do you analyze the specificity when there's patients who never meet mycological criteria, but they have a pulmonary positive angiographic sign. In fact, it seemed to, our experience initially seemed to suggest that there's quite a few patients on antifungal prophylaxis who would not have a positive serum galactomannan. Maybe they couldn't be evaluated with bronchoscopy, and yet they had a positive occlusion sign. And it seemed that the prophylaxis did not affect the positivity of this test to the same degree as serum galactomannan. And this actually raises an interesting question that we suggested to the EORTC, but we said maybe pulmonary angiography could be an alternative way to upgrade patients from possible to probable invasive mold disease. But so to try to get around this, we used our own clinical definition. This was blinded. The clinical diagnosis was blinded to the radiologist. And we looked at specifically the patients who never met mycological criteria for upgrade to proven or probable infections. This was 51 patients. And if you look at the patients who had a positive occlusion sign, all but one, the final diagnosis was on clinical grounds invasive mold disease, that we didn't isolate anything else. They respond to antifungal therapy. There was one case that was a false positive. This was a patient who had Staph aureus bacteremia with septic thrombosis of the lung. But I think that the key point here, though, is really looking at the patients who had bacterial pneumonia, other diseases. Very uncommon to see a positive occlusion sign in these patients. And we did have maybe possibly one false positive, one false negative test, although this patient went to hospice, so they couldn't be fully evaluated. Now let's just contrast this with the halo sign. Frequently, in patients who have positive halo signs, we have patients who have bacterial pneumonia, we have patients with lymphoma, and you do miss about 1/3 of invasive mold disease in our experience. So this suggests to us that it is a very useful tool for catching an additional third of patients who do have invasive mold disease that don't meet mycological criteria. And if we put all these patients together in a basket, based on the clinical diagnosis, we think it's as specific as any of the other signs. Now, to kind of put this in the clinical context, then, what is the value of CT pulmonary angiography? It could be argued that, or even giving contrast, that once you have a patient who's very high risk, who, if they have these suspicious infiltrates on their CT, they have the risk factors, they're already at probably 40–50% chance it could be mold, and you're going to treat anyway, so what difference does it make if you have a test that confirms that? That's sometimes an argument that we hear raised against this. And it's true that, if you look at a positive halo sign, it doesn't necessarily confirm. And this is what I'm trying to do, is show you the post-test probability. I like to think of these things in terms of probability. So if I'm starting at 40, 50%, and the patient has a halo sign demonstrated, it slightly increases the probability, but if the halo sign's absent, we can't rule it out because it's not seen in 1/3 of patients. And the size of these circles is in relation to how often we see these signs. For example, when we saw patients who had a reverse halo sign, very uncommon to see, but it was very, very suggestive, very high probability the patient had invasive mold disease. Interestingly, in our center, only one was mucormycosis. All of these were aspergillosis. So my feeling is it may be more of an indication of aggressive fungal disease rather than specifically mucorales. But we also noticed that the hypodense signs seem to be quite good. And a good thing is when you do CT pulmonary angiography, that by giving contrast, even if you do not do angiography per se, you begin to improve some of the earlier detection of some of these other signs, such as the hypodense sign. And so we could detect hypodense signs earlier in patients. Sometimes you'll do pulmonary angiography, 5 to 10% of patients may cough, or there may be an artifact where it can't be read. And now the radiologist, even though the patient has gotten contrast, they can go back and look at the scans, and sometimes you can detect a hypodense sign. And we've begun to explore the hypodense sign a little bit more carefully, because when you're detecting them earlier, there's also opportunities to look at it not only in the atrial phase, the arterial phase of the image acquisition, but you can also capture images in the venous phase. And this may actually reveal some interesting differences, especially if you use algorithms to compare the central necrosis density versus the outer peripheral ring. And we think that this may be a useful backup sign for detecting invasive fungal disease in the lung, even when angiography fails. And in fact, a cutoff of a certain range could be defined for patients during the venous phase. It seemed to suggest when you could call it a hypodense sign that's higher probability for invasive mold disease. So maybe there's, I think, we need to look. One of the advantages of giving contrast is you can see hypodense signs more frequently, but this is how I would put the pulmonary angiography test in relation to these tests, that it's the only test that significantly lowers the probability of invasive mold disease in patients because of the much lower likelihood ratio compared to the other CT signs. So what we found is that it reduced the post-test probability in patients who had a negative CTPA, a negative occlusion sign in their infiltrates. Their probability of invasive mold disease is only about 2%. And the 95% confidence intervals go from 1 to 10%. So this is in the range where you can really begin to convince clinicians that maybe this is something else. We need to establish an alternative diagnosis. And maybe, especially if you have biomarker support, you can stop antifungal therapy. And without even having a formal guidance or a formal antifungal stewardship program, when this test was introduced and was being used by the hematologist, they believed in it, and they started stopping antifungal therapy on their own. They self-governed themselves by giving a test that they believed in, and we saw significant reductions in the use of both intravenous and oral antifungal therapy. So certainly I think that there is a role. Maybe we need to go back and not just focus on the CTs the way we have been for, interpreting them and the signs that we've discussed for the last 15 years. There may be opportunities for helping us improve managing our patients. So I think of CTPA as a way to characterize angioinvasive lesions, but people are really focused on what about in this earlier phase, or the things that can be done to even improve CT scanning and improve management of patients. And maybe the next major leap forward is going to be doing low-dose CTs. It's now possible to do these CT exams with about 85% less radiation that we did in the past. We no longer do chest x-rays in hematology patients. And in fact, we've started a protocol now where in the first 24 hours of fever, patients will immediately go to a low-dose CT. And sometimes you will characterize these lesions later, and this just will mean that the patient will have to have careful follow-up within a week. But in some cases, the radiologist is detecting lesions that even within this first 24 hours of fever are highly suggestive of an invasive mold disease. And when they look at the scans, instead of seeing a full occlusion sign, they're seeing a partial occlusion sign of the fungus eating into the vessel. And as we're collecting data, we think that there may be a sign that can be evaluated even in these patients who have these smaller central lobar lesions that may be very, very suggestive and selective for invasive fungal disease. So I'd like to stop there, and thank you very much for your attention.